All right, welcome back to another PCBH Corner. I'm really excited to be joined by Dan Mullin, and I'm going to give him an opportunity to introduce himself. And I was telling him before we hit the record button that Dan is one of the people that I always make a list that I want to connect at conferences and CFHA, and Dan is always at the top of the list, but I've never been able to do it. This is the first time that I've actually been able to have a conversation with Dan about his thoughts because I see what he posts on the listserv, and every single time he posts, I'm just like, hell yeah, like this is just great. This is what we're talking about. So I'm just really, really pumped for one, selfishly, that I get to have this conversation, and then for viewers to be able to watch this as well. So Dan, I'll pass over to you, maybe kind of give an introduction where you're at right now. And then also the first question that we always love to ask people, and particularly people like you that are doing incredible work, that are founders, leaders within the field, what got you into integrated care? What's your integrated care story? Were there any accidents that led you here? Was it more intentional? Just anything that got you into integrated care. So I'll pass it over to you.
Yeah, thanks, and very happy to share my thoughts. Let's see. I was first exposed to primary care when I was a graduate psychology student. Um, I I did my PsyD at Spalding University in Louisville. A few other integrated care people have come out of there, Sarah Sholey and Ben Miller, who a lot of people have heard of. And we were there when we had professors who started getting a little bit of grant money and projects to begin partnering with the federally qualified health centers in Louisville, and they said, "Hey, we does anybody want to do an extra therapy practicum in addition to what you're already committed to? We've got some money to have someone spend a day or two a week in the FQHC." I didn't know what an FQHC is. I didn't really know what primary care was, but I was at the point in graduate school where I said yes to everything and was trying to impress everyone. And so I went in, and once I was there, and I compared working in that environment to more traditional environments like counseling centers or psychiatric hospitals or community mental health, there was never really a question of going back. I couldn't really imagine myself working in private practice. I think for a variety of reasons, my personality, my interests was just a better fit for primary care. And so when I started looking for internships in psychology, this was my internship year was 2005, 2006. So there weren't a ton of opportunities back then. And the place I ended up was University of Colorado, Denver, working under a wonderful supervisor, Deb Seymour, and working in the Department of Family Medicine there. And that's what exposed me to the world of family medicine education and the role that psychologists could play in help training primary care doctors. I'd say I also began to understand the differences between family medicine and internal medicine, and really started to buy into the values and mission and history of family medicine. So when it came time to do postdoc work, I was looking for more departments of family medicine where I could train, and ended up at University of Rochester. And that really started to expose me more to the history of family therapy and the connections between family therapy, family medicine, and primary care. And I had not had a lot of family therapy in my own graduate program. I had been focused much more on health psychology. And I think that experience, it just continued to fuel my interest in family medicine, which is what led me after my postdoc years to come to UMass to work with Sandy Blunt, who was well known and had written one of the first books about integrated care in the 90s. And he brought me in, and I began work here in one of the primary care residency practices in family medicine in central Massachusetts. So I work at the Barry Family Health Center. I just passed my 15-year anniversary.
Let's
Uh,
go.
yeah, 15 years in the same primary care practice. It's a more rural practice, although it's what Massachusetts people call rural. It's not what Montana or Wyoming people would call rural. Um, And I love it. They're my family, they're my team. It's hard for me to imagine going elsewhere. Over the years since I've been at UMass, I got here for a year. It was the first time since kindergarten I hadn't been in school, and it was very disorienting. And so I started taking epidemiology classes and really enjoyed it, and ended up getting my master's in public health, which really helped, I think, round out, or I think complement my PsyD background. Um, I tell people that I was trained first as a clinician, then as an educator, and finally I'm learning a bit of research, though I don't consider myself to primarily be a researcher. And
Now you are,
yeah,
if I'm wrong, talking to Roger Kessler, you are overseeing the,
yeah,
that's
yeah. I probably am selling myself a little short on the research.
yeah.
If I'm around clinicians, I'm one of the most research people in the room. But if I'm around researchers, I'm the most clinical person in the room.
It's a way of keeping you humble, right? Like,
Yes.
it's like,
Yeah, absolutely. So I love it. Some of my other passions are motivational interviewing, and thinking about how to train everybody that is interested in motivational interviewing. Also, the practice I work in has been a real leader in treatment of opioid use disorder, and I've become real passionate about that. My philosophy of practice is that the things you should care about sort of academically need to be the things that the community you serve need. And in our community needs more help around opioid use disorder. And so that's where I spend 10 years of the time of my focus academically, is because that's what I say, in primary care, the epidemics choose you, you don't choose the epidemics. So the work you're focused on, the things you care about, need to be driven by whatever the issues are. Maybe if I worked in South Texas, I don't know, but my passion would be probably migrant health. And how do we address the local, very serious needs of the migrant population or the asylee population, because that's what they need. And I try to, when I work with learners, and both medical learners and behavioral health learners, trying to figure out, well, what is primary care? What is its strengths? What is its focus? What are we focused on today? The answer to that question always needs to be, well, what do the people that live in your town need? That's your focus.
Dan, can I say, this is a big,
Yeah.
like, sensing even through Zoom your passion for this. Like, this is why I love every single time you write an email on the listserv, because you can sense, like, the way you write, there is a value, there's a mission, there's a passion. And what a beautiful thing, as you were saying, like, also the history. It's like, what a systemic way to approach, what a primary care way to approach, about community. What is the focal points? That is phenomenal. I did want to ask one quick question before jumping into another thing.
Yeah.
Again, as you going back to your doctorate program, in a really cool progression, as you said here, about the health psych and exposure to it. I had no idea you had the University of Rochester. That's phenomenal, about the family systems approach and whatever. You said something about, you said yes to everything. And one of the things that we always try to, we have students a lot of times reach out and internship and all those things. Was that something, as you also said very quickly after that, it's like, I was trying to impress people. Was there any value associated with, like, saying yes?
I think some of it is strategic. I don't think we should be ashamed of that. I think when you're a student or you're a learner, I sometimes have seen students and learners who say, well, I don't want to do that because that's not, I don't want to work with that professor, or I don't want to work on that project because that's not my passion. And I would be very careful about that approach to decision making. I think a better approach to decision making is to look around your faculty and say, who are the people that impress me the most, that are the most dynamic, innovative, engaging people? What do they care about? And how do I get close to them so I can learn from them? The content that they're talking about is not really the important thing. that what you're trying to learn is their approach to being a professional, whatever, professional psychologist, professional social worker, professional physician. And I worry sometimes that undergraduate and early graduate students are too focused on what is my pet issue, what is my passion, as opposed to who are the role models that I need to get next to that can teach me to grow. Yeah. Yeah.
Such a different kind of approach, as you were saying, right? Like it's
Yeah.
not, like you said, not content, not
Yeah.
it's their approach. Oh man, that's cool. That's
Yeah.
cool. Okay,
Yeah.
so let me ask you this: the one thing that we were starting to do, and again, I
Yeah.
wish we would almost hit record as soon as we start talking, was this idea about what you have observed being changing priorities within primary care. I'm just going to give that as a prompt
Yeah.
and go. Where does your mind
Yeah.
go about what you have seen, and then what do we do?
Yeah. So let me try to connect this a little bit to my own history and that story that I just gave. Again, in my graduate training, I was in a health psychology track, and I was really exposed to health psychology. And I think early on, I didn't have a clear understanding of the relationship, the overlap, but differences between health psychology and primary care psychology. I think
Ah,
a lot of behavioral health, mental health people, when they hear primary care, they think it's a synonym for medical. So, for example, I've been at conferences where I tell people I work in primary care, and I've been doing that for 15 years, and they say, "Oh, that's not new. I work in primary care too. I've been in oncology now for 30 years." And I don't I that I that's not what primary care means. And so I think that's where I was when this started. I thought primary care just meant medical. So let me come back to this primary care health psychology distinction in a couple minutes, though. I just want to set that aside now. When I first, I think we're at a real fork in the road with what primary care is going to be in this country. And to illustrate the point, let's just imagine a continuum where on the one side, your primary care provider, usually a physician or nurse practitioner, right? Their job is to be there and be available to you when you need help, and maybe to check in with them once a year to do some anticipatory work or screening work. But the primary role of the relationship is oriented around the idea of the patient going to the doctor and saying, "I have this worry, or I have this pain, or I have this need. Doctor, can you help me?" And I think let's call that like relationship A. What I'm observing increasingly over the last 10 years is we're moving towards a different kind of relationship B, which is about everyone is assigned a primary care doctor or a primary care office, primary care team. This gets you to the population health idea, but that the relationship has shifted, and the team now sees their job as telling all of the patients, "Let me tell you what you need to do to be healthier. Let me tell you what you need to do to live longer and be able to work and not suffer." And I really bought into this idea of relationship B for a long time, but at where I am now, I'm pulling back from it. It's beginning to make me nervous, because what I'm seeing is that the primary care doctors, all of their attention and energy is being driven by the administrators who are trying to get the population's A1C score to change, their hypertension to change, their PHQ-9s to change. And the doctors are no longer orienting their attention, their effort, their time, and they're not available anymore to be timely and available to their patients and say, like, "Tell me what it is you need and how I can help you." Instead, the administrators are pushing the clinicians to say, "Let me tell you what you need to change, because you need to get healthier so that our scores improve, so that our payers are happy and our revenue goes up." Not so they get rich, some of them in some systems, so they get rich, but not in the FQHCs, not in many of the nonprofits. But this is a fundamentally different vision. And I think if we all just pause and think about our own families and our own health and what we need when we have health problems, I'm a little worried that we're surrendering the idea of primary care as being this place that can be a constant in your life if you need it, and that when you have something that's important to you, they can help you address it in a timely way. I think increasingly the hospital systems are using primary care to try to push the population to change. And then if you have an urgent need, a timely need that's important to you as a patient, go to urgent care.
Urgent.
And I, especially being in family medicine, that's reprehensible to me. Like that, I do not believe that urgent care can replace the original functions and purpose and value of primary care. Yeah.
Dan, my mind, and again, this is why I wanted to talk to you.
Yeah.
What a really awesome kind of justification about these two different kind of philosophies and these two different kind of things. So where do you see, I mean, in your own work right now, you know, obviously having this revelation and having this realization, what are you doing? I mean, what is the conversations? How are you approaching patient care? What are things that you're trying about?
I mean, well, first of all, I don't have an easy answer. I'm much better at describing problems than I am at just generating quick solutions to massive problems. I think, I think the response to what I just said will be, well, why can't we do both? That ideally we should be able to create a space in which we're doing population health, in which we're doing preventive and screening type work, where we are proactively advising people about how to avoid the development of a chronic condition or how to reduce the morbidity and issues associated with a chronic condition. And we should be able to do that, and we should be able to be available in a continuity form on demand when a patient has a need. I think, yes, that would be wonderful. Unfortunately, the workforce is really, really struggling. We were struggling before the pandemic, and we're struggling even more now. The rates of burnout amongst primary care providers is through the roof. And I also think amongst behavioral health people working in primary care, burnout is in the rise. My own, my schedule templates for clinic were all designed before the pandemic. And when I was sort of counting on like a 10 to 15% no-show rate and a 15 to maybe 20% cancellation rate, which gave me like generally in a 65 to 70% utilization rate year after year. That's about where we hovered in my practice. But that waste or inefficiency was really helpful because it let me be more available for warm handoffs. Right. It let me be more available for crises. It let me do some of the administrative work and phone call collateral work. What we've seen across the practices in my system for behavioral health, the utilization rates have shot way up since the pandemic. In the first 6 months, when all the patients were sitting at home next to their phone, our utilization rate was almost 100%. Right. Like there was no-show, no cancellation. It has come back down a little bit, closer to the pre-pandemic levels, but not nearly. So that, yesterday was my long day in clinic, and I had 13 people. And, I think I probably had one or two 15-minute encounters, mostly 30-minute, and a couple that I stretched out to 40 or 45 minutes because there was a crisis or an urgent need. So as an academic, I can go into primary care and I can do that one day a week and survive. But I don't know how a full-time behavioral health clinician
does a day in and out
could ever do that on a sustained basis. So let me come back to the question, like, can't we do both of these things? Can't we? And I think the answer is maybe. In some clinics that feel like they're adequately staffed to meet their community's needs, you can do both. But I think most clinics don't. If you ask them, are you adequately staffed to meet the needs of your patients? I think most people say, no, we're not. We're perpetually trying to hire at a rate that will get us up to what our community needs. I think it makes it really hard to try to do both those things.
And
I think yeah, go ahead. Yeah,
so, sorry, keep where your thoughts going.
Yeah.
And I also want to go back because I love what you were saying about the difference between primary care and health psychology, because I think it's a really big difference.
Yep.
And it sounds like if a clinic is kind of deciding between these two different kind of relationships, A or B, right?
Yeah.
Is my mind making the right prediction that it's like, hey, I would probably suggest like focus on A, like focus on like allowing people to get in when they feel like a problem is there. Where does your mind go with that? Would you say that is true?
Well,
or again, does that depend on the community?
I would make a distinction between administrative demands and the cultural values. So the administrative demands are going to, for the foreseeable future, they are going to continue to push on, we got to move people's A1Cs, we got to move their blood pressure, we got to move their PHQ-9 scores. Organizations are locked into payer contracts now where you will not be able to get administrators to talk about anything else. They are always going to talk about that now. That's their job. They have to.
We have departments with it now, right? We have whole departments about that.
Yes. Yeah. But all of their lean management improvement, quality improvement tools, all of those important tools that they have are being directed towards those metric-based work, that when it trickles down to the patient's experiences, the doctor is driving the agenda more. The doctor is the one deciding what we're talking about and what the priorities are. And also, when I want to see my doctor, I can't get in to see my doctor because they're so full, chasing these patients around these metrics. I think what you have to do is you have to continue to create spaces in your practice with your clinicians where the clinicians, with or without the administrators, can talk about these other core values and strategies for hanging on to them. And when managers start to treat primary care providers like interchangeable parts, and when they start to ignore continuity and the value of continuity, I think the clinicians need to push back. So a practical way to do this is there is a continuity measure that has been developed and is getting some traction nationally. I believe it is HEDIS certified now. But it is a measure that can be deployed in EHRs that can allow practices and primary care physicians to measure and report the continuity of care that the PCPs are providing their patients. And the goal is not 100%, right? If I fall down and hurt myself right now and I want a doctor this afternoon, I don't necessarily have to see my favorite doctor, my regular doctor, if it's urgent. I'm not saying it always has to be continuity, but the pendulum has swung too far. And the lean management people, they came from Toyota. The car industry invented interchangeable parts, right? We need to remind them that PCPs and therapeutic healing relationships are not necessarily interchangeable parts, and that there's a value to continuity of care.
There's a value of continuity of
care. Right. But if we're going to do that, you can be like me and stand on your soapbox and go and have rants about continuity of care. But if you were going to get serious about it, you would start measuring continuity of care, reporting it, and just looking at comparisons between providers and practices in your system. Because continuity of care it's a core value, it's a core principle of primary care. Lower A1C scores are not a principle of primary care. They're a patient outcome. But all these payer metrics are patient outcome driven. They're not supporting activities that align and strengthen you to your core mission or even your core model. I mean, if we want to go into PCBH talk, we'd say, we need to be measuring, if we are trying to do high fidelity PCBH implementation in our practice, then we need to be measuring PCBH fidelity and reporting it and setting transformation goals related to that. We can't build, you can't use A1C, and I don't think you can use PHQ-9 and blood pressure to tell you everything you need to know about the quality of your PCBH implementation. You need to measure PCBH fidelity if that's your goal. Or
I gotta ask, before you go in, again, you're gonna get me excited right now. What would you say would be those things? What would you say those, if you're thinking high quality, like high fidelity PCBH, what would be those metrics? What would be those measures?
Well, some of that we need to, some of that I would challenge the PCBH researchers to do a better job of aligning, of measuring the impact of PCBH fidelity on patient outcomes. So, for example, back in the early mid-90s, Kirk Strassel had a chapter that laid out a report card for integrated. I don't even remember if he called it integrated primary care, what his term was then. But in that, he included, in fact, I can screen share this report card with you.
Do it up. Let me make sure. Hold on real quick. Yep, you should be good.
This was a foundation of my dissertation. The roots of this thing go back to here it is. Here's the citation, 1997. And this was his sample report card. And obviously, this is a lot about PCBH. We're talking about Kirk Strassel here. He has this. And I've seen current PCBH people talk about row 7 here. Practice penetration. What percentage of the practice, of the patients associated with the practice, have had some sort of consultation with a behavioral health provider? And I see PCBH implementation projects sort of aspire to a high percentage here and aspire to raising their percentage. I think that theoretically that's probably a good idea, but what's a little frustrating or disappointed is that we are 25 years out from when this was published, and this is still very much faith-based. He made up these numbers, 6, 15, and 20%. He pulled, I don't know where he pulled them from, but he pulled them out of nowhere.
Yeah.
But right now, I don't know that we've advanced much further than that.
On I would say almost in any metric related to PCBH.
Right.
Even when we talk, and I'm sure you have these conversations, because oftentimes it's like, well, how many visits and all these things? Like, we don't know. Like, this is largely just made up. Again, I think that's the important thing about tracking data over years to look at. But 100%, like, all these things are just, arbitrarily sounds right. I don't know.
So I think I'd like to see us, I'd like to see somebody that I'm not going to do it, but I'd like to see somebody else dive in and let's just start by describing the variation in penetration rates. Because again, if I worked, I don't know, where's an example? If I work in San Diego with, an uninsured, underinsured, again, refugee migrant population, I don't think 20% penetration rate would be adequate.
Correct.
I think it would need to be 80%.
Correct.
But then, I know people that serve the wealthier suburban communities of Boston, all privately insured, all way above U.S. median average, all facing far fewer racial and social, obstacles to health. Maybe we don't need a 20% penetration rate in that population, right?
I remember Jeff Ryder talk about this, right? Like, he was saying about like how, even like a ratio of PCPs to BHCs, like if you're working in a homeless clinic, like that ratio might need, exactly.
Maybe 2 to 1.
2 to 1, right?
Yeah.
It's really, for sure.
Yeah. So I'd like to see us do more. I'd like to see the PCBH folks try to add a bit more rigor to that. But your question was, what should we be doing? What should we be thinking about with fidelity? Well, I do think penetration rate is part of that. You should be intentional about it. You should be thoughtful about it. And most of us should be trying to raise our penetration rate. Uh, at the same time, my big thing is for the clinic to be deliberate and thoughtful about their approach to people with chronic mental health and substance use. So again, I work in a relatively rural practice. We have no mental health partners. There is essentially nowhere to send children, and there's definitely nowhere to send most adults for ongoing like psychiatric management or very little counseling that's available. And so, what do I do with someone who has bipolar disorder and a substance use disorder? I'm going to have to design a primary care behavioral health service that addresses their needs. And one of my concerns when I talk to my VA colleagues and my DoD colleagues is that they just live in a very different world than the federally qualified health center.
No doubt, man.
Right? Like, first of all, if you're in the DoD, once somebody's disabled, like, they're not really your problem for very long, right? And if you're in the VA, like, you're on the same electronic health record as your mental health partners. And your system has some ability to influence how mental health interfaces with primary care and what those pathways and connections can be. But once you move out of the VA system, now it's a completely fragmented system of care in which primary care has no ability to dictate to the mental health how they make themselves available and what resources they provide. Now, I don't want to pretend like it's easy in the VA. I just want to say that they're fundamentally different structures. And some of the PCBH writing and some of the best thinking and development around PCBH has its roots in the DoD and VA system. And we need to be thoughtful about how the population, again, you design your care to meet the needs of the population that your clinic serves, not what the book tells you primary care is supposed to be.
Dan, again, you get me hyped about this because this is such a big thing and a misconception, right? Because like some people will read like, it's supposed to be 1 to 6 visits. Like, I don't know. Like, that doesn't sound a lot like primary care in a lot of ways. It's not like a PCP's telling a person, hey, you're on your 6th visit, got to get the hell out. And as you're saying, I work in a community health center and FQHC as well. We're in a rural part of state of Washington. Grace, love, and compassion to our community mental health agency, but they actually tell our patients anytime we refer, go back to CHCW because you can get in to see them. And there's also, my mind goes, like you mentioned about like, severe mental illness, chronic mental illness. There's a part of me that is like primary care due to continuity might be one of the most beautiful places to make sure that you can help people with those concerns because of this longitudinal relationship. Now, to your point though, if you apply a very rigid, indiscriminate view of PCBH, that's not going to be helpful for those individuals. Again, I love that, man.
Yeah. So I think those are all the thoughts. Let me come back around to the health psychology thing.
Yeah, please.
Because I told you I would do that. So I think where I can remember being exposed early to health psychology and being very optimistic about the ability for a psychologist, or I'm not a psychology snob. You can be a social worker, an LMHC, MFT, whatever. I was optimistic about the ability of behavioral health people to help patients change behavior related to disease. I still think we need to try. I still think that's part of our job, but I also think we need to be careful about overselling the ability of counseling or conversation to result in behavior change. Come back to what I was saying earlier about the administrators are telling the PCPs that their job is essentially to get the patient to take their meds, get the patient to go to the specialist, get the patient to lose weight, or God, get into substance use, like get the patient to stop drinking. Right. And then they listen to behavioral health people, psychologists like me, talk about things like motivational interviewing. And they think, oh, well, we train the doctors in motivational interviewing, and then the patients will change their behavior. Where I think we need to be more honest is like, look, we prescribe all sorts of medications that aren't very effective. It doesn't mean they're bad, doesn't mean they're garbage, but even many evidence-based treatments
Correct.
There's a statistic that behavioral health people don't learn called number needed to treat. How many people need to receive this treatment in order to benefit? So for a drug like a statin for cholesterol, what is the number needed to treat? How many statins do you have to give to somebody who hasn't had a heart attack in their 60s to prevent the next heart attack? I can't rattle the number off the top of my head, but it's a big number. It's like 100, or it's at least 50, okay? So let's apply that to we need to start applying that stuff to our behavioral health counseling. What is the number needed to treat for the best motivational interviewing in the world for smoking cessation? It's probably, it's at least 10. That you would have to provide the absolute best motivational interviewing in the world to the next 10 smokers that walk in the door to get one of them to sustain quitting for a year. And what I worry about is that the administrators are not taking into consideration these numbers needed to treat. And they think if they just push the doctors harder to get the patients to change behavior, that somehow all these metrics around blood pressure and A1C and are going to move in the right direction. And I think it's we may have oversold the ability of counseling to change everyone who walks through the door for a practice.
Could not agree more. And what's so interesting about this is something we talk, obviously you work with, trainees and whatnot. When we get interns, psychology interns and fellows into this, it's like, hey, we have to be real about what we're doing here. Like that it's like, we have this belief. It's like, oh, we're here. We're going to just, every single person that has diabetes and they see us, we're going to just magically bring down everybody's A1C. It's like, no, that's not what we have.
If we had the ability to do that in a 15-minute conversation, we would all be so much richer than we are. We wouldn't even be psychologists. We'd be car salesmen. We would be just, we would have so much money. But we can't just get people to do what we want all of the time through a quick conversation. So let me come back to the health psychology, primary psychology, though. So part of this with number needed to treat and understanding your population is as behavioral health people, when we see evidence and we think we know what intervention works or what doesn't work, we need to remember the differences in the population that the intervention was designed for. So let me use cognitive behavioral therapy for insomnia as an example. If I work in a sleep medicine practice in Manhattan and you have to go see your primary care doctor, get a referral to sleep medicine, you have to pay cash, you have to wait 3 months to see me, and then I have an hour and I do an intake and you show up and then you get the CBT for insomnia. It is going to work the same intervention will work 100 times better than if I stand at the front door of primary care and screen everyone for insomnia and try to offer the exact same CBTI intervention to the next 100 people that come through the door. And this is a thing about screening and all of our enthusiasm around screening is we're not, you're gonna find all these people with condition, and then you're gonna apply the evidence-based intervention to it, but you forgot that most of the people you identified are pre-contemplative.
Exactly.
And when you go in, but in order to get into that door into the sleep medicine clinic in Manhattan, 0 of them are pre-contemplative.
You got to have agency. You got to be no doubt.
Right. So a great thing about primary care behavioral health is that we reduce barriers to accessing treatment. That is our goal, that we should do it. That's really important. It's a core value or principle of primary care and primary care behavioral health. Reduce barriers to accessing treatment. But when you reduce barriers to accessing treatment, don't forget, you get people with a very wide range of readiness to change. And so you can't just launch in with your evidence-based intervention, expect it to work the way it would work in a specialty setting. And this is a critical point for behavioral health trainees, because they read in the textbook what the evidence-based intervention is, they make the right diagnosis, and then they think connect intervention to diagnosis, but they completely forgot the differences in the people they're meeting.
Dan.
Yeah.
God damn it, man. I cannot. This is what I'm so grateful for this conversation and the broadness of this conversation about the different topics and the different things with this. And I know we're getting up on the 45-minute mark. Listen, I might have to twist your arm to do a part 2 of this later on, and it's going to happen. Is there any final thing that your mind goes to that just would be, just really important to you? It would be a mission or a value to you to talk to our communities about, talk to the people doing this work, the providers, any suggestions, guidance? What does your mind go to as we wrap up?
Yeah, I mean, the part that sustains me is the connection with the patients. I get very frustrated with the health system. I get very frustrated with the challenges of trying to do what we're doing. But I will say that, I started by saying, I'm celebrating my 15th anniversary in the same primary care practice a couple of weeks ago. And, the long-term relationship with my PCP colleagues and with my patients is what sustains me. And I think a lot of people, when they get burned out, they believe, well, if I could just reduce my clinical work and do more other kinds of tasks, I'd be happier. Maybe, but it's also important to just find some way to keep reconnecting with what you enjoy about meeting the patients that you meet. Because in my experience, that is a much more potent sustaining factor. Is that? Yeah.
Dan, that hits me, because that's a big thing too, right? About us indiscriminately thinking about like what is going to protect me and stuff. And oftentimes we said we almost erode the very values, the very thing that connects us to humans. So man, my gratitude, man. I thank you so much again. I'm going to miss you at CFHA next year, though. Hopefully we get you to San Antonio, and then we'll talk more. So thanks for people watching. Obviously, comment, ask questions. Obviously, Dan is very responsive to things on the listserv and emails, and for sure will be responsive to this. If anything that your mind goes to, you want more clarification about, please reach out. But Dan, again, my gratitude.
Yeah, thanks for giving me a chance to talk. Thanks.